Diabetic foot infections and osteomyelitis. Diabetes mellitus and peripheral arterial disease represent two of the fastest growing and most challenging medical surgical conditions facing the world today. In the previous review for lower extremity arterial disease, I discussed the peripheral arterial disease, how peripheral arterial disease is inflammatory damage to the vessel wall due to endothelial cell dysfunction resulting in stenosis and occlusion. Diabetes doubles the likelihood of developing peripheral arterial disease. For every 1% increase in hemoglobin A1C, there is a 26% increase in the risk of developing peripheral arterial disease. And 50% of patients with diabetic foot ulcers have peripheral arterial disease. Many diabetic patients may be asymptomatic for peripheral arterial disease, and others may have an atypical pain pattern due to peripheral neuropathy. Peripheral arterial disease patients with diabetes are 5 to 10 times more likely to progress to major amputation than peripheral arterial disease patients without diabetes. Patients with both peripheral arterial disease and diabetes have a typical clinical picture of vessel involvement. Peripheral arterial disease in general is focal and most commonly in the superficial femoral artery, causing calf pain. However, peripheral arterial disease with diabetes is often diffuse and severe disease, more commonly involving the tibial arteries with a high prevalence of long vessel occlusions. The collateral formation is also reduced in patients with diabetes, making them more susceptible to severe acute ischemia. Ankle brachial index in patients with diabetes is less reliable due to false elevation secondary to vessel calcification and non-compressibility. Therefore, ABI greater than 1.3 is associated with increased cardiovascular event rates, and normal or subnormal ABI in a diabetic patient should prompt the possibility of even worse vascular disease than in non-diabetic patients. Medical management of peripheral arterial disease in diabetics is to keep hemoglobin A1C lower than 6.5%, blood pressure lower than 130/80, LDL levels lower than 70, and to have aspirin and Plavix in the treatment regimen. Now let's talk about osteomyelitis. Diabetic neuropathy and peripheral arterial disease, coronary artery disease, and end-stage renal disease on hemodialysis routinely accompany the patient with diabetes with lower extremity infection. 60% of moderate to severe diabetic foot ulcers have osteomyelitis. Complicating medical comorbidities include controlled or uncontrolled diabetes, renal insufficiency with or without hemodialysis, malnutrition, tobacco usage, ability to offload, obesity, and compliance issues. All these conditions tend to impact wound healing negatively and must be thoroughly explored by the wound specialist. Osteomyelitis can be acute osteomyelitis when the first episode resolves within 6 weeks, or chronic, lasting longer than 6 weeks, or recurs. Infected diabetic foot wounds are often less symptomatic than non-diabetic wounds, exhibiting only subtle or even a complete absence of signs. Many times, recalcitrant hyperglycemia may be the only clinical finding, indicating a severe infection of a diabetic foot ulcer. But in general, if a diabetic foot ulcer fails to heal after at least 6 weeks of appropriate care and offloading, one should suspect osteomyelitis without systemic manifestations of infection. Therefore, it is important to distinguish wounds with vascular insufficiency from those without. The signs of osteomyelitis could be signs of diabetic foot infections are basically divided into non-limb threatening and limb threatening categories. Toxicity signs, sausage toe, that is pain, redness, swelling, warmth, and tenderness at the site of infection. Infections surrounding cellulitis. If cellulitis is greater than 2 centimeters, limb threatening. Abscess or gangrene is limb threatening. Foul odor could be there. The symptoms can occur over 1 to 2 weeks. There can be abrupt fever, chills, malaise. Patient with diabetes, pain may or may not be present depending on peripheral neuropathy, and fever is usually absent, or there could be chronic low-grade fever. On inspection in diabetic patients, chronic osteomyelitis rarely occurs at the medial malleolus, pretibial areas, or heels. But there would be history of foot trauma, necrosis overlying the bone, or underlying open fracture. There can be induration or pus drainage, friable granulation tissue. On examination of such patients, you will find limited range of motion, decreased use of the extremity, wound tunneling to bone. Most important assessments at this stage is the bone depth. Palpable bone or bone fragments exposed or visible within the wound should generate serious concern for concomitant osteomyelitis. Diagnostics starts at the bedside. Diagnostic measures include probing the wound. The ulcer is typically examined with a blunt style cotton probe, either direct pressure exposure of bone or a positive probe to bone test. Probing can also detect sinus tract formations. Persistent sinus tract, like a deep penetrating ulcer, and sinuses are usually located between the toes, leading to the small bones of the foot or from the plantar surface of the foot, communicating with the calcaneus and talus bones. These sinus tracts could be present for months or years. Other tests include CBC with CRP levels and ESR levels. Cultures in diabetic ulcer with concerns for osteomyelitis are best done after debridement. Wound cultures should be taken by obtaining tissue from the debrided wound base or by aspirating pus. The gold standard for osteomyelitis is the quantitative bone biopsy and culture of the involved bone, with the histologic finding of inflammatory cells and osteonecrosis is the gold standard for diagnosing osteomyelitis. Imaging for osteomyelitis involves X-ray. Findings are abnormal after 10 to 14 days. Significant changes in X-rays are seen once osteomyelitis extends past 1 centimeter and is involved with 30 to 50% of bone structure. Magnetic resonance imaging is the most sensitive and specific. We can also get CT angiogram, which is the new standard in assessing peripheral arterial disease and planning for surgical or endovascular intervention. Computer tomography with PET scans or radionuclide scan or WBC scan are all modalities that can help. Finally, the treatment of osteomyelitis. The recognition of non-limb threatening versus limb threatening infection is paramount in the patient with diabetes, facilitating a prompt treatment protocol. A strict patient-focused protocol is required, which should be inclusive of antibiotic selection, preoperative optimization and revascularization, surgical approach, debridement, definitive wound closure, and postoperative follow-up. Surgical amputation for osteomyelitis depends on many factors, and often these patients are medically unstable and present with complicating comorbidities. The presence of soft tissue, gas emphysema, or necrotizing infection warrant urgent surgical intervention to prevent limb loss, potentially superseding medical optimization or revascularization. Surgeons' ultimate goal should be to preserve foot function and stability while preventing further tissue loss and subsequent breakdown. Healing osteomyelitis with antibiotics alone is difficult but possible. Treatment usually lasts 6 weeks or more of parenteral therapy with a 50% success rate. The treatment is antibiotic therapy based on the culture results. The most common causative microorganism is Staphylococcus aureus. However, the presence of methicillin-resistant Staphylococcus aureus and fever on initial presentation, and increased serum creatinine, prior hospitalizations for diabetic foot infections, and gangrenous changes are related to treatment failure. Hyperbaric oxygen improves available oxygen at the bone site and improves leukocyte killing ability through oxidative mechanisms. Besides, hyperbarics may enhance antibiotic activity. It is also thought that osteoclastic activity and osteogenesis improves with the use of hyperbaric oxygen. Thank you.